Yeah, let's look now at the principles of treatment. Yeah, pardon? General principles. Immune mediated uveitis involves use of anti-inflammatory and immunosuppressive agents. Always keep in mind that drugs used to treat uveitis have potential side effects. Like any other, not only this, any other disease, if you are treating, you should always be aware that there are side effects to all these things. Weigh against decision to treat. Mediatrix preparations, you have got short-acting ones, tropicamide, 0.5% and 1%. It has a duration of action of 6 hours. Cyclopentolate, 0.5%, 1% drops, has a duration of action of 24 hours, long-lasting, longer than the tropicamide. This cyclopentolate is 24 hours. Phenephrine, 2.5% and 10% has a duration of action of 3 hours. This is the shortest acting. So these mediatrix is to break the synechnias. When there is a uveitis, there is inflammation in the anterior part of the uveal tissue. You find that the iris is stuck on the lens. The iris may be stuck somewhere else like that. So first you want to stop, to break that, that synechnia. And these are the drugs you use, the mediatrix. Bear in mind, some are short acting, others are long acting. Yeah. Yeah. Long acting omatropine, 2% drops, has a duration of action of up to 2 days. Atropine, 1%, the most powerful, cycloplegic and mediatric, with a duration of action of 2 weeks. So if you use atropine, the pupil now, what will happen is you are trying to break the synechnia. Maybe because of it's constricted because of the inflammation there. You use atropine, you are going to dilate, break down the synechnia, but then there is a danger that now the pupil can still have synechnia in the dilated position because this is long acting. So the ideal is you put in eye drops that will break the synechnia, the stiffness of the iris onto, say, the anterior surface of the lens, but allows movement over, say, a period of 24 hours. Pupils are supposed to focus. Once you go bang on just to dilate, you're still going to have stiffness of the iris in the dilated position onto the anterior surface of the lens, and it means you have not achieved anything. So these are things you have to consider which drug you are using. It's not jumping, atropine. No. I think the best is the shorter acting, the better, and you assess the results. Because if it's shorter acting, it will dilate, then you within maybe 24 hours again come back. If you are putting in 3-4 times, it means it will have 3 episodes of dilating and constricting, which is what you want. You don't want it to be stuck in a dilated position onto the lens. It's as bad as constricted and stuck on the lens. Indications for mediatrix, these are the pupil dilating drugs. One is to promote comfort by relieving spasm of the ciliary muscle and the pupillary sphincter, usually with atropine or omatropine. Omatropine is a weaker, atropine is a stronger one. Once the disease shows signs of subsiding, a short-acting preparation can be used. You want that. You don't want it to be bang and it remains, long-acting, remains stuck now on the lens surface in a dilated position. You haven't achieved anything like that. So this helps to, it promotes comfort. This use of mediatrix, it promotes comfort. It also helps to break down the recently formed synechiae, where the iris is stuck. We're referring that as synechiae. So the use of this is to break down the recently formed synechiae. With intensive topical mediatrix, atropine, epinephrine, or subconjunctival injection of mediatrix, adrenaline, atropine, procaine in eyes not responding to drops. You may use these. These are injectable. We inject subconjunctival and have the same effect. But you don't go in straight for subconjunctival. It's in the eyes not responding. That's where you can use that. It means you start with what you think can work. If it's not working, that's when you go to the long-acting. Tissue plus minogene activator can be injected in the anterior chamber with a 25 G needle to dissolve that fibrous material, which is a fibrous exudate, and help break down. This is like the end game. If you have tried that, it's not working, you may try this. It will digest out, all the fibrous stuff out, all the persistent fat. It breaks them down, and the pupil is again able to dilate and constrict. Also, the issue is to prevent formation of posterior synechiae. Use of short-acting mediatric allows mobility of the pupil. Because why is it mobility? This is short-acting. It means over a short period, the pupil goes back to constricted position, then back again dilates with the drug, goes back. That way, the iris is not stuck in one position for a long time, and it avoids synechial formation. So use of short-acting mediatric allows mobility of the pupil and prevents formation of the synechiae in the dilated position. In mild cases, use mediatrix at bedtime to prevent difficulties with accommodation during the day. Why? Because at bedtime, by the time they wake up, that effect of the mediatric is gone. If you are going to give them a stronger one, they'll wake up with dilated pupils. They can't focus properly during the day. Choroiditis. Choroiditis, inflammation of the choroid. May be focal, multifocal, or geographical, or diffuse in nature. It does not usually induce vitritis in the absence of retinal involvement. Active choroiditis is characterized by a round yellow nodule. Okay? Vasculitis may occur as a primary condition or as a secondary condition adjacent to vasculitis. Both actually can be this involvement more common. Active vasculitis is characterized by yellowish or gray-white patch perivascular cuffing, which may be associated with hemorrhage. Principles of treatment in uveitis. General principles. Immune-mediated uveitis means use of anti-inflammatory and immunosuppressive agents. Always keep in mind that drugs used to treat uveitis have potential side effects, like any other drug. It's not only here. Whatever drug you are using in medicine, you know that there are potential side effects. Weigh against decision to treat. Mediatrix preparations, short-acting, these are the types. Tropicamide, 0.5%, duration of action 6 hours. Tropicamide, it means within 6 hours it has faded out. So you can give it 4 times a day. times a day, unless people are going to be kept awake at night. You can give it twice a day within the 50 days. So that when it's time to go to sleep, they are comfortable. One is that's the tropicamide. The next one is cyclopentolate, 0.5% and 1%. Duration of action 24 hours. This one is stronger than the first one. You can see duration of action. If it has a duration of action of 24 hours, you are going to give it only once. Normally, you give this where you've got stuck, synetia, pupils is stuck. You use that one, the long acting, to try and break down in the synetia. After that, you have to go on a weaker one. Which one? Which one? You went back to another slide. Where are we first? There.
We did this.
Which one?
This one.
To prevent formation of post-stress and use short-acting immediate. Okay. Where are we? That's there. Now we are coming here. Just a minute. We're sorting out one or two issues. So indications for topical steroids, treatment of acute anterior uveitis. Initially, therapy involves installation at hourly or even more frequently according to the severity of the inflammation. That's the person who is treating who will assess. This one is maybe serious, you give more frequently. Once controlled, you do that, you drop down to 2 hourly, followed by 3 hourly, then 4 times a day. In other words, you have intensive treatment, you see there is progress, you reduce that intensity of treatment until you can settle for 4 times a day. Treatment of chronic anterior uveitis. Exacerbations are initially treated in the same way as acute anterior uveitis. Following cessation of treatment, the patient should be re-examined within a short time to ensure that the uveitis has not recurred. Ask them to come after 2-3 days. You check what is happening. If things are okay, they seem to be okay, you can even put them on the weakest steroid to maintain them for a period. But you keep on checking things up. Complications of topical steroids use. One is the elevation of intraocular pressure. Commonly in susceptible individuals, those who are steroid responders, long-term use may result in glaucoma in many individuals. So you can't be on steroid drops for long. So this idea of this is the drug I use, which you will find a lot of patients will come, no, what they don't know is but they don't know the side effects. So the patient should be warned. It's not about the medicine you take. The frequency you take, it also matters. Complications can follow it. I've seen a lot of it. No, the doctor, a clinic officer, someone, a clinician must look at it, whether it's worth it to take now, today, although you take it every day. So cataract complications, we've done the elevation of intraocular pressure. Cataract commonly induced by steroids. Risk increases with dose and duration of the therapy. Corneal complications secondary to infection with bacteria and fungi. Recurrence of herpes simplex, keratitis, and corneal melting if you use the steroids for a long time. These are all side effects of steroid use. Systemic complications are normally rare, usually rare. because you are taking, these are topical steroids you are taking. So systemic are rare. But if you are going to take steroids, orally, yes, there will be systemic complications. So for eye drops, systemic is rare. Periocular steroid injections, advantages over topical administration. Therapeutic concentration behind the lens may be achieved. Water-soluble drugs incapable of penetrating the cornea, when given topically, can enter the eye transsclerally when given by periocular injection. You inject below the conjunctiva, and that fuses in. That's what is called periocular injection. Amen. References, Mr. Jack J. Kansky. Any questions, ladies and gentlemen? I know it has not been easy to follow, but you read through, I'm sure, this slides is set and study peacefully. Any questions? Any questions, please? Karen.
Good morning.
Morning, mommy.
I wanted to ask on slide 5, the 5th slide.
5, okay. Yeah, let's see. Slide 5. Clinical feature,
Yes.
isn't it? Yeah.
Yes. Now on the note, the improvement of inflammation, just on the note, can you help me explain on the note again?
Improvement of inflammation defined as a 2-step decrease in level of activity or decrease to inactive. The level of activity of the inflammation inside. If you see there are so many cells, then after some time, the cells are getting less and less because there is improvement. So if you can think it has gone down 2 steps down in the level of activity, that is improvement, which you can document. It's not saying you stop treatment, it's improvement, which means you can continue treatment until there are no cells. That's complete, treatment. Even when there are no cells, you ask them to go home. Can you come after a day or two? You recheck if they relapsed or not. So it's not about no cells now. No, yes, they are okay. Let them go. Come back after a day or two. You review them again. If things are still okay, give them maybe the last review. They are still okay. You can discharge them. Are you clear, Mami?
Yes. Thank you so much.
Okay. Any other question?
Good
I
morning,
have another
sir.
question.
Tasila, okay. That's Tasila, okay.
Yes.
Yes,
I wanted to ask about the symptoms. Yes, I wanted to ask about the symptoms because we've dwelled much on the signs that we'll see when we examine the patients, but what will the patients present with? Like when they come, what will move them to come? How will they be feeling when they have uveitis?
Okay, if you are talking of acute uveitis, they are going to have redness. This is a definition. Features of inflammation will be there. they will have redness normally around the limbus. If it is in the chronic stage, there may not be any redness of the eye. But when you check the anterior chamber, it's full of cells. The acute one, you are going to have that redness. Ask, is it traumatic or it's not traumatic? Was there trauma associated with that kind of thing? Then you can say, I think this is traumatic uveitis. If there is no issue of trauma, but they are showing signs of uveitis when you put them on the slit lamp and you examine, it's uveitis, acute uveitis. I must mention here, there are cases of chronic uveitis where there are no signs. You know, patient looks, the eye looks completely like normal, but can't see properly anyway, because the inside is full of inflammatory cells. Those are chronic cases, chronic uveitis. You will find such type of cases. In chronic uveitis, long-standing cases, the eye looks completely white, but when you go on the slit lamp, you find plenty cells in the anterior chamber. That is chronic uveitis. This is the grading of the acute one, where there may be just 0 or maybe 1 or 2 cells, 3 cells, you know. Here, we are seeing through, this is clear cornea, and this is the lens part. This is the iris. We are on the iris here. And you can see this fluid level, white stuff in the anterior chamber. This is the hypopyon. Obviously, when you reduce your beam and you throw it through the lens, you will see within the anterior chamber sparks of cells there. They will be present. But this is severe. You can see the fluid level, the hypopyon. This one there. Just go back again. As you can see, the hypopyon outside on the sclera is all inflamed. That will be a sign you will see. When you look at the eyeball looks inflamed around the limbus. The cornea has no vessels, so it still remains clear, and you are able to see through the anterior chamber. You are able to see the inflammatory cells inside which have settled inferior as hypopyon there. These are keratic precipitates pigmented. Once precipitates get pigmented, it's a long-standing case. It's not an acute issue. This is a chronic issue. These are inflammatory cells stuck onto the posterior part of the cornea, the inside. This is how they appear. Another question, ladies and gentlemen? Karen again, ask mommy. Turaya kanovunga. Tapakwa kanovunga, tapava insoni. Wadi waweta wakoseka. Yes, mommy, can you ask anything?
Doctor, you said in eyes that are not responding to drops, we use subconjunctival injection. Is it because the uveitis is excessive or because the medicine is not powerful? Which one is it?
Except the uveitis is what, excessive?
Or maybe the medicine is not really as powerful to eyes, to positions where the eye is not responding to eye drops.
No, okay, positions where usually you don't have, there are very few cases like that. The cases I've seen myself, some people in a severe case, when you examine a patient, it's a severe case, they will start to give that subconjunctival instead of waiting for eye drops. But even eye drops on their own, you can give within 24 hours, you should be able to see improvement. the patient responding. Usually injections, they will give to break the synechium. In severe inflammation, you find a lot of doctors where an injection to break the synechium is indicated. Then you add also the steroids. Because the inflammation has been there for a long time. Apart from the inflammatory cells which are there, there is also a bit of synechium, and you want to break that. So they will give something to break the synechium, injectable. Okay, Mami.
Yes, doctor, thank you.
Thank you, Mama. Another question, please. If I may ask you, when I say to break the synechium, which drug do you think they will give? Injection? Busy consulting each other.
Now she has gone mute.
Okay, so dilating drug. No? Also, you give some conjunctival and it works. Breaks down any, any synechium which is there. Then after that, you put the drops. Any other questions, please? We are done, eh? My friend. If there are no questions, we are done.
Then we are done.
Okay.
Maybe just a concern for the next